Hi everyone. In this video we're going to be looking at thyroid testing, the reference ranges of conventional and functional medicine. My name is Dr. Greg Celaya. Let's first start with looking at lab reference ranges, or the normal range which your lab numbers are compared to when you have lab work performed. Most people think that these normal ranges are set as a standard across all labs, but they're not. Labs follow Clinical and Lab Standards Institute guidelines, which are recognized by the FDA. These guidelines suggest that every lab create their own normal ranges from people that come into their labs and have tests performed. They suggest that they use a sample of 120 normal people as a population, but can be as little as 20, and they are based upon geographic location, age, sex, race, etc. In addition, they suggest that the normal zone be compiled from 95% of the tested individuals. This leaves only 5% that are outside the range, 2.5 high and 2.5 low. Let's take cholesterol for an example. Let's say you go to the lab and you sit down, and on your right side is a person that is over-medicated with cholesterol medication, and their cholesterol is 30. On the other side of you is a person with familial hyperlipidemia, which is a condition where fats aren't processed correctly, and their cholesterol is 500. Will those people be put into your normal, to your averages? Perhaps. Are most people healthy that go to the lab, or are they normal? It's a good question. With functional medicine, we use ranges of truly normal, healthy individuals that are narrowed down for optimum health. Most doctors never even look at your lab value, but they do look at a place where it is called flagged, or if it's outside the normal range which the lab suggests. This can be a problem because you really never know what optimum health is at those levels. Thyroid stimulating hormone is a hormone that's produced by the pituitary, and it's telling the thyroid to speed up and produce more hormone. It's a negative feedback loop, and we'll take a look at that here in a minute. But you can see that the typical lab range is 0.5 to 5.5. Those numbers are way too great, and usually when I see somebody around 3.5 and up, they very commonly have hypothyroid issues. So we take a look at the functional range, and it goes from 0.3 to 2.5. And I actually like to see somebody about 1 to 1.5. We need to understand a little bit more about how thyroid stimulating hormone works. We can see that everything here is balanced. So T3 and T4, which are thyroid hormones, and thyroid stimulating hormone are nice and balanced. Everything's working well. So TSH is in the 1 to 1.5 range, and also T3 and T4 are balanced according to functional medicine standards as well. So here we see a condition called hypothyroid, or where your thyroid's not producing enough hormone. So we can see here T3 and T4 are decreased, and TSH is increased, trying to get your thyroid to produce more hormone. So as a result, your TSH numbers are growing. It's trying to tell your thyroid to do more and more and more. So we see a couple of examples here of what hypothyroid can actually look like. So you see overweight. In addition to, you see swelling and edema in the eyes. Real common when you first wake up in the morning. The number one cause for hypothyroid is a disease called Hashimoto's disease, where it's an autoimmune problem, where your body has actually attacked the thyroid gland, causing it not to be able to produce thyroid hormone. Next, we have hyperthyroid. So your body's actually producing too much thyroid hormone. And you can see here that T3 and T4 increased, where TSH, meaning thyroid stimulating hormone, that hormone that's produced from your brain to your thyroid, is getting less and less. So it may be going from 2.5 all the way down to 0.2, sometimes even 0. Here we see a condition called Graves' ophthalmology. We'll be talking about autoimmune markers that are prevalent with hyper and hypothyroid issues later. Not all Graves' patients have this, just the unlucky ones. The problem with this condition is once you have it, it doesn't go away, even if your thyroid levels actually start to get better. They can do surgical approaches to help minimize this, but it's a tough one to have. T4 makes up about 93% of your thyroid hormone. It's inactive, but it gets converted in the liver, about 60%, and your gut, about 20%, and also your peripheral tissues, and it's converted into T3, which is the active thyroid hormone. T4 and other thyroid hormones are tyrosine-based. It's an amino acid, and then an iodine's placed at each or all of the corners of the molecule. This arrangement makes it fit into the receptor site or it doesn't. And if it doesn't fit, the hormone is not active and does not have any effect on the cell. This happens for a good reason. Can you imagine all the thyroid hormone being active at the same time? Certain cells close to the thyroid would always be in overdrive and get a lot of activation where others far away may not get any at all. In addition, T4 lasts longer in your system than T3, the active hormone. T4 is bound to thyroxine binding globulin, TBG for short, and it binds thyroid hormones in circulation. It's one of three, but it is the one that is most prevalent in how much it can actually carry. T4 free is not bound to protein and actually has a greater propensity to be converted to T3, the active thyroid hormone. And as you look at the typical ranges here, for T4 bound, we've got 4.5 to 12, whereas the functional range, we have 6 to 12. So we tighten up those numbers a bit. And T4 free, 0.8 to 1.7. And functional ranges are a little bit different as well, 1 to 1.5. Most doctors only check TSH and T4. And if you're lucky, they may check a T3, but it's unusual. T3 is the thyroid hormone that does all the work. It's actually produced about 7% from the thyroid gland, and other areas it's done by conversion. T4 is converted into T3 by an enzyme called 5' deiodinase, which is an enzyme dependent upon selenium. It's an essential mineral. And here again, we have T3 that's actually bound to protein. And it's just a transport mechanism. It's not an active hormone at that point in time till it becomes free. And free is what we usually look at very commonly. But you can see here, again, the typical lab ranges versus the functional lab ranges are quite different. 2.1 to 4.5 for normal ranges and 3.0 to 4.5 for functional. T3 uptake is done to see how much thyroxine binding globulin is available. TBG is a protein that carries most of the T3 and T4 in the blood. You know, when you get lab testing, your provider may recommend a T3RU, and that's what this is called, if you have signs of hyper or hypothyroid problems. Here we can see the difference between T4 and T3, and just in its secretion, we can see the big difference in how much is actually made. 20 to 25% is actually produced of the thyroid of T3, where 70 to 80% is by conversion in the liver, in the gut, and peripheral tissue. T4 is only produced by the thyroid. Half-life is the amount of time that it takes for the quantity to reduce to half its initial value. So you can see that T3 kind of gets to half its value in one day, whereas T4, it's 7 days. So the inactive hormone stays around for quite some time, where T3 active hormone is used up pretty quickly. The potency of each is quite different as well. So T4 obviously is just normal potency, where T3 is 3 to 4 times more potent than T4. Reverse T3 is another thyroid hormone, and it's made from T4. And it looks a lot like T3, but it's a little bit different. We'll see in the next slide. The problem is that most doctors do not ever check reverse T3. Approximately 60% of T4 is converted into T3, and 20% is converted into the inactive form of thyroid hormone, known as reverse T3. Reverse T3 can be good and bad. Even though it is inactive, it'll still bind to T3 receptors and block T3 from stimulating the cell. Too much or too little cortisol that is produced by the adrenal glands will increase circulating levels of reverse T3 also. It's due to suppression of liver detoxification and clearance of reverse T3 from excess cortisol production. Stress can not only cause signs of hypothyroidism, but it will also impair the liver's ability to detoxify. Cortisol will also suppress thyroid-stimulating hormone production, resulting in low thyroid function. The list is long for things that can cause high levels of reverse T3. We have immune system issues, high adrenaline, excess free radical damage, aging, fasting, drugs, stress, prolonged illness, low iron, low B12, Lyme disease, diabetes, and the list goes on. To better assess reverse T3, there is a ratio that I like to use, and it's using the free T3 divided by the reverse T3. The ratio should be over 20. If you're using total T3, it should be 10 or higher. It's important to make sure we have enough T3 in the system and not so much reverse T3, because reverse T3 will bind to those receptor sites, creating a problem with the cell not getting enough thyroid stimulation, and therefore decreasing the cell's metabolism. Take a look at T4. It's made of thyroglobulin and 4 iodines. And thyroglobulin is a protein that's very abundant. There is an enzyme called 5' deiodinase that takes the iodine off of T4 to make T3. There's also a completely other enzyme called 5-deiodinase, there's no prime there, that takes other iodine off of T4 and makes it reverse T3. As you can take a look at the differences here, it's really close, reverse T3 to T3. It's almost like a mirror image. And therefore, you can see how reverse T3 can actually bind to T3 receptor sites. Most conventional providers don't even bother looking at autoimmunity. They just treat the low or high thyroid issues. And it's a very important thing in functional medicine because when you have one autoimmune disease, you're 70 to 90% likely to have an additional. And these autoimmune conditions can really cause some very serious diseases. The first we have is TGAB, which is thyroid globulin antibody. And thyroid globulin is a protein involved in thyroid hormone production. By the way, don't confuse this with thyroid binding globulin, which transports thyroid hormone through the blood. Anyway, this can be ordered for hyperthyroid evaluation and management and for tumors and for cancer. Next, we have TPOAB, or thyroid peroxidase antibody. And it's an enzyme that helps activate iodine in the making of thyroid hormone. It also helps connect tyrosine together, again, for making of that thyroid hormone. This test is used to determine if a person has Graves' or Hashimoto's disease. Thyroid stimulating receptor antibody, and there's two types of antibodies that attach to proteins in the thyroid to which TSH normally binds. This can be seen in Hashimoto's and Graves' disease. TSI, or thyroid stimulating immunoglobulin, is seen with Graves' disease. One big problem that we have is when this is positive and we have a negative TPO, we see the risk of Graves' ophthalmopathy increase. In other words, the bulging eyes. And last, we have TBII, which is thyroid binding inhibitory immunoglobulin, and it's important for diagnosing Graves' disease. So you can see there is a lot more to thyroid than just running a TSH and T4 like your conventional doctor would do. We look at everything. We look at all the different hormones, T3, T4, inactive T3, T4. We also look at autoimmune conditions. We narrow down our lab values to be less broad than what conventional medicine actually does. And we especially want to look at reverse T3 because when it is high, you're not binding T3, the active hormone, to cell receptor sites, and therefore could have symptoms of hypothyroid issues. You can also look at your thyroid lab tests and see everything is normal. And if that's the case, we'd also look at adrenal glands, as they can actually have very, very similar symptoms. And those different tests will be covered in a different video as well. Thanks for tuning in. I hope you've learned some things about your health. If you'd like to know more, please go to my website, drcelaya.com, where you can schedule for a free 15-minute consultation or become a new patient. We'll look into your issues with lab work to get to the root cause of your problems. If you'd like to see more videos about your health, please subscribe below.